diffuse hypotension, which might cause catastrophe. Okay? And in patients with low ejection fraction and coronary artery disease, this might be a catastrophe. Okay? This is the patient with the near occlusion patient. And at the same session, we treated the left carotid also from the same radial artery. This was the radial artery approach, and you see it was done at the same stage, but also I had a lot of difficulty in managing this patient also. I'm against it, okay? Sometimes we are doing this because of, I'm working in a private hospital and the patient, I don't want them to come again and then pay again, okay? So sometimes I'm doing this, but I'm against it.
So actually one of the risks would be severe hypotension after the procedure.
You can have myocardial infarction after this case because of diffuse hypotension. You can also have renal failure. You can also encounter cardiogenic shock, okay? And these are the risks, and these are very important risks. But I have a study. It shows us that it can be done. So simultaneous carotid intervention can be done. However, as I said before, I'm against it. This is the study, and the results seems to be not bad, and it might be, this study might be hypothesis generating to begin a study, but I'm strongly against it. So, embolic protection devices. This is another case. This is another case I accomplished without any protection device. The latest ECG guideline upgraded its recommendation from embolic protection devices to 2A, okay? However, the evidence remained C. That means we don't have any meta-analysis, we don't have any randomized trials to prove this recommendation. So, but before I continue with my proof, not using embolic protection devices, let me finish my case. And you see again, this is a tight lesion, and we have a stent implantation without any embolic protection. And this is the diffusion MRI before and after with no difference. And the next day I discharged the patient. It doesn't mean it should be done, but we don't have any evidence. So, but I have a lot of evidence that is against protection devices. For example, we have the SPACE study. And this secondary analysis of the SPACE study trial does not support the need for any protection devices in carotid artery stenting. So we have the ARCHER study. This is not the study. The generation is going better with the filters, but the stroke rates raises according to that by the ARCHER study. And we have 2 randomized trials with MRI that are indicating no protection devices are better regarding microemboli. Distal filters are, the results with the distal filters are worse than without protection. These are
Why
no, because this is a device is bulky.
So you can't.
So many manipulations, you can push everything.
So this is another case I have done without any protection. You see, first we thought that this was a thrombus, and we did a lot of predilation, and the stent jumped on the proximal part here. Again, this is the residual lesion, so we had to put another self-expandable stent here. We did a lot of predilation, and we understand this case was actually a case with huge amount of calcification, not a thrombus. So this is the end result, and we were able to discharge this patient after 2 days without any complication. So what I need to say that the embolic protection devices is mandatory, I need a meta-analysis, okay? I need meta-analysis in the combination of CAVATAS 2, EVA 3S, SPACE, ICC, ARCHER, or I need a multi-center trial, okay? We don't see anything. This is another study with over 200, there are 2 studies that are indicating it is safe to do carotid artery standing without any protection. So this is another, you see the near occlusion. And also this case was managed without, here you see the predilation without an embolic protection device. And this is the end result after stenting, and you see we have no any kind of emboli in the brain. So, and we have also scientific evidence. It's not far. In 2016, this is the ICC study, a multivariate analysis from the ISCC study indicated that embolic protection device is not one of those predictors of periprocedural complications. So, we started the study, a multi-center study, and we have a lot of difficulty in recruitment, patient recruitment, as you would imagine. And here is our preliminary results with no difference between the two approaches. And I go very fast. You see here another patient. It's very tight, severe internal carotid artery stenosis. And here you see, here you see the end result without any protection device. And here's the end result without any protection device. So the other controversy is the radial route for carotid artery stenting. The conventional approach to access the common carotid artery during endovascular intervention is through the femoral artery. And although a cumbersome access technique, bypassing the aortic arc may prevent some embolic complications. This is a hypothesis, okay? So I prefer using the as I said, the radial approach. And this is the left internal carotid artery lesion. This is an easy one because we have a bovine arc here. If you have a bovine arc, then you should go radial or you should go brachial. You have no other option. So instead, this was not difficult to manage for me. We have post dilation here because you have to, the stent should touch the vessel wall, okay? If you have the feeling that, and you have the proof that the stent is not touching the vessel wall, you should do post dilation, okay? Or if you do the predilation with a smaller balloon, you need post dilation with a bigger balloon. But if you do the predilation with a bigger balloon, you don't need any post dilation. And taking into account that the post dilation causes a lot of stroke in subgroup analysis of different studies, and I think we should avoid post dilation. Do it with predilation.
So predilation with, I mean, what value for example?
4.5, yeah.
That's big.
Yeah.
You don't do direct stenting.
What?
Direct stenting.
If you go, if you can cross the lesion with direct stent, it's okay. But this is a bulky device. Sometimes you need predilation. And if you don't predilate, and if you go with a bulky device and try to cross the lesion, so this is a randomized trial, the red card star for carotid artery stent. It can be done by the radial approach. This was a randomized trial, and this is the end of my presentation. So I think we can talk during lunch.
Yes.